Hello everyone. Moving towards the new topic, that is CA breast, that means carcinoma of the breast. This breast cancer is very common. It is the commonest malignant disease mostly in the western countries like in England, and this disease it causes about 12,000 deaths annually. It is estimated that 1 in 14 of all female children born will develop the disease during their lifetime. And in spite of an immense amount of investigations, there is still no known cause for this disease, and its natural history is obscure. The women between the 45 to 55 years of age are most frequent victims of this disease. But many factors are known to influence its frequency. While any portion of the breast may be attacked, the disease commences most frequently in the upper and outer quadrant of the breast. The lump is painless, and the geographical distribution is very common in western world, mostly in England, and there is genetic history. It occurs more commonly in women with family history of the breast cancer. Then there is endocrine factor is there, that is it appears to be common in this breast cancer is appear to be common in nulliparous women than in women who have born many children and have breastfed. It is also less common in women who have their first child at early age, especially if associated with late menarche and early menopause. So this is the introductory part of CA breast, which is this CA breast is most common malignant disease in women. The age group that is affected is 45 to 55 years of age. This disease commences mostly in the upper and outer quadrant of breast, but any part of breast can be affected, but most commonly it commences in the upper and outer quadrant of breast. The lump of that is present, which is painless. Then geographically, if you see, it is common in the western world, and there is a family history of breast cancer in the affected females. There is an endocrine factor that may play a role in CA breast, that is this disease is common in nulliparous women, while it is less common who had their first child at early age. Then pathologically, this CA may arise from epithelium of duct system anywhere from nipple end of major lactiferous ducts to the terminal duct unit, that is breast lobule. Now the spread of the breast cancer. The local spread is the tumor increases in size and it may invade other portions of breast. It tends to involve skin and it penetrates to the pectoral muscles and even to the chest wall. So locally it will spread to skin, pectoral muscles and chest wall. The lymphatic spread may occur in two ways, that is by emboli with CA cells, malignant cells or carcinomatous cells. So this emboli will consist of, or it is composed of, carcinoma cells. And secondly, the lymphatic spread is by permeation. It includes actual growth of carcinomatous cells along lumina of lymph channels. The axillary nodes and the internal mammary nodes are involved comparatively early. Later, the supraclavicular lymph nodes, the opposite breast, and the mediastinum are possible resting places for carcinoma cells. So this is the lymphatic spread. Lymphatic spread will occur in two ways, by emboli and by permeation. When in emboli, it is composed of carcinomatous cells being swept along the lymphatic vessels by lymphatic stream, and by secondly by permeation, that is actual growth of CA cells, carcinomatous cells, along the lumina of lymphatic channels. The lymph nodes are involved are axillary lymph nodes and internal mammary lymph nodes. They are involved comparatively early, and later on supraclavicular lymph nodes, the opposite breast and mediastinum are involved. Okay. There may be a spread by bloodstream. It is by this route that skeletal metastasis may occur in the lumbar vertebra, femur, thoracic vertebra, and the skull. And they are generally osteolytic, pathological fractures occurring most often in ribs and vertebra. In most instances, it is by way of bloodstream that metastases arrive in liver, lung fields, or brain from the breast. But secondary deposits may also carry to the liver via lymphatics within the rectus sheath and falciform ligament. The adrenal glands and the ovaries are also common sites for blood-borne metastasis. Okay, so the spread of mammary carcinoma or CA breast is by local spread, lymphatic spread, and spread by bloodstream. Now the clinical types of carcinoma of breast. The next point is clinical types of carcinoma of breast. The first clinical type is serous carcinoma. It is serous carcinoma is the commonest form, and it occurs in middle-aged or elderly women. There is abundant fibrous tissue, that's why the lump will feel very hard and it will be irregular. Its contour tends to be irregular. As the tumor advances, there will be indrawing of nipple, the skin overlying, and the tethering of pectoral fascia deeply. In late cases, there may be blue d'orange as well as ulceration of skin, and fixation to the chest wall may be present. So what is blue d'orange skin? It will look like orange pill. That's why the name, that is beauty orange skin. If the breast containing serous carcinoma is cut with knife or on cut section, how it will look? There will be the growth cuts with grating sensation. If you cut the growth, it cuts with grating sensation. The cut surfaces are concave. The color of the cut surface is gray and may show small granular whitish streaks, and there is no capsule, the tumor being fixed within the breast tissue only. So this is a serous carcinoma. Once again I'll repeat, serous carcinoma it is the most common form, and it occurs mostly in middle-aged and elderly women. It contains abundance of fibrous tissue. That's why the lump feels very hard, and its contour tends to be irregular. As the tumor advances, there may be indrawing of nipple, the skin that is overlying, and tethering of the pectoral fascia deeply. Then in late cases, there will be bluey orange, ulceration of skin, and fixation to the chest wall. The breast will fix to the chest wall. And if you on cut section, there will be grating sensation while cutting. Then the cut surfaces will be concave, and the color of cut surface is gray. There will be small granular whitish streaks will be present, and there will be no capsule. The next type is atrophic serous carcinoma. It is also present in aged women, thin women with small breast. It is very slow growing carcinoma, and it takes about 10 years or more to ulcerate. So in atrophic serous carcinoma, it occurs in aged thin women who are having small breast. This carcinoma is very slow growing tumor, and it takes about 10 years or more to ulcerate. Next one is duct carcinoma. It is not seen below the 40 years, and it is to be distinguished from papilloma. It may be impossible to distinguish from duct papilloma without any evidence of biopsy, because both the duct papilloma and duct carcinoma will present with blood-stained discharge from the nipple. But the differentiating point is duct carcinoma will occur after the 40 years of age. It is not seen below the age of 40. Next clinical type is medullary carcinoma. It accounts for about 5% of breast cancer, and it affects a earlier age group than the average. The primary tumor is soft, and it is circumscribed and may attain a large size. The prognosis is more favorable than for commoner serous type. Once again I will repeat the medullary carcinoma. This medullary carcinoma accounts about 5% of all breast cancer. It affects the earlier age group. Then this tumor is soft and it is circumscribed. It may become larger, and it has a better prognosis than serous type. The next one, the fifth one, is inflammatory carcinoma, or it is also called as mastitis carcinomatosa. Inflammatory carcinoma or mastitis carcinomatosa. It is rare, but it is highly aggressive cancer seen usually during pregnancy and lactation. So this carcinoma is highly aggressive, but it is rare carcinoma and mostly seen during the pregnancy and lactation. And this disease breast is often painful. Pain is more in this disease. Then there is warm red skin, and there will be cutaneous edema. There will be blockage of subdermal lymphatics with carcinoma, and it spreads over large area, that is 1/3 of the breast. Once again, I will repeat: the inflammatory carcinoma or mastitis carcinomatosa. It is rare. It is highly aggressive cancer, usually occur during pregnancy and lactation. The diseased breast is often painful. The reddened skin feels abnormally warm, and there will be cutaneous edema, which indicates blockage of subdermal lymphatics with carcinoma cells. This usually extends over the considerable area, that is over about 1/3 or more of the breast is involved. There may be retraction of nipple, and the important differential diagnosis is breast abscess. You have to differentiate this condition with breast abscess. Okay, the patients with mastitis carcinomatosa show no pyrexia, no or leukocytosis, and edema of skin is usually more widespread than the abscess, and the diagnosis is confirmed by biopsy. So this is inflammatory carcinoma or mastitis carcinomatosa. Then there is clinical staging of the carcinoma of breast. When the patient is first examined, instead of categorizing the growth in vague terms as if early or moderate advanced or advanced, it is highly desirable to have some conventional method of expressing of the stages. So there are various stages of clinical stages of the breast cancer that we'll going to learn. There is one classification, that is TNM classification, and this TNM classification will include tumor, node, and metastasis. But another classification that is present, and it has increased acceptance, that is first stage. There are about 5 stages. The first stage is in stage first, the growth is less than 2 cm in diameter. The growth is confined to breast only, and there will be no adherence to pectoral muscle or to the chest wall. So in stage first, The growth is confined to breast only. There is no spread. The growth is confined. The growth is less than 2 centimeter in diameter, and the tumor must not be adherent to the pectoral muscles or to the chest wall. This is stage first. Now in stage second, it is same as that of stage first, but there are affected mobile lymph nodes in the axilla of the same side. The growth is 2 to 5 centimeter in diameter. So the clinical stage second, it appears same as that of stage 1. Growth is about 2 to 5 centimeter in diameter, and the affected mobile lymph nodes in the axilla of the same side. The next one is stage 3. It includes skin involvement, that is PUD orange is present, is larger than tumor. But it is still limited to the breast. The tumor is fixed to the pectoral muscle but not to the chest wall. There will be edema of arm. Then homolateral axillary lymph nodes matted together and they are fixed to the chest wall, or homolateral supraclavicular nodes mobile or fixed, and there is edema of the arm. So in third stage, the skin involvement is there. The skin will look like PUD orange, that is look like orange pill, that is larger than the tumor. The tumor is fixed to the pectoral muscle, but it is not fixed to the chest wall. And there will be edema of arm and homolateral axillary lymph nodes. They are matted together, or they may be fixed to the chest wall, or the homolateral supraclavicular nodes, they are mobile or fixed. This is stage 3. Then moving to the stage 4. In stage 4, the skin involvement is wide, including skin involvement is wide. There will be complete fixation of the breast to the chest wall. The lymph nodes and blood-borne disease, blood-borne distant metastasis will be there. So stage 4 will include widespread of skin. The skin involvement is widespread. There will be complete fixation of tumor to the chest wall. The distant metastasis, either with blood-borne or lymph-borne, is there, and that will include opposite side of breast or axilla, or deposits in the bone and viscera such as lung and liver. The stage 1st and stage 2nd, they are operable. Then the next point is prognosis of the disease. It depends upon the size of primary tumor and its hormonal reception status, histological state of axillary lymph nodes. Axillary lymph nodes free of carcinomatous cells, then 75% patients will survive for 10 years. If the cancer or the carcinoma is limited to the breast only, and if the axillary lymph nodes are free from the cancerous cell, then 75% patients will survive for 10 years. Then if 1 to 3 axillary lymph nodes are involved, then 50% patients will survive for 10 years. If 4 or more lymph nodes are involved, then 25% patients will survive for 10 years. In stage 3, 5% patients will survive for 10 years, and in stage 4, the survival rate is 0. So this is the prognosis of carcinoma breast. This prognosis will depend upon the size of the primary tumor or involvement of the axillary nodes, or according to the stages. Okay. Once again I will repeat, when the axillary lymph node is free from cancerous cell, then about 75% of patients will survive for about 10 years. If 1 to 3 axillary lymph nodes are involved, then about 50% of patients will survive for 10 years. If 4 or more lymph nodes are involved, then 25% patients will survive for 10 years. And in stage 3, 5% patients will survive for 10 years. In last stage, that is stage 4, the survival rate is 0. Then one more disease is present in the clinical stages or in the clinical types of carcinoma of breast, that is Paget's disease of nipple. This is one of the clinical type of carcinoma of the breast. This Paget's disease is superficial manifestation of the underlying breast carcinoma. It presents as eczema-like condition of the nipple and areola, which persist in spite of the local treatment. The nipple is eroded slowly and it will eventually disappear. Microscopically, there will be large ovoid cells with abundant clear pale staining cytoplasm. Treatment of this disease is mastectomy, and no palpable lump is the good prognosis of the disease. So this is the Paget's disease. Once again I will repeat, Paget's disease of the nipple. It is a superficial manifestation of the underlying carcinoma. There will be eczema-like condition of the nipple and areola. The nipple is slowly eroded and it will disappear. And microscopically, Paget's disease is characterized by large ovoid cells with abundant clear pale staining cytoplasm. And the treatment for Paget's disease is mastectomy. And if there is no palpable lump, then that is the good prognosis of the disease. Lastly, moving towards the treatment of the cancer of the breast. The treatment of the breast cancer is determined primarily by the stages of the disease. The first stage and second stage, they are operable. You can operate when the patient is in stage first or in stage second. The aim of surgery is to ensure the long-term control of the disease in breast and in axilla, then to conserve the local form and the functions of the breast, and to prevent the metastasis. So in these stages, in stage first and second, they are operable, and the surgery and the irradiation are complementary to each other. The surgery that can be carried out are, first one is radical mastectomy and second one is simple mastectomy. In radical mastectomy, the breast and the associated structures are dissected, and this excised mass will contain the whole breast, then skin with nipple, then fat fascia from the lower border of clavicle to upper border of rectus sheath, then sternal portion of pectoralis muscle and its sheath, then pectoralis minor and its sheath, then costocoracoid membrane, then all fat fascia and lymph nodes of axilla are removed, then fascia over the external oblique, serratus anterior, subscapularis and rectus abdominis muscle that should be removed. So these structures are to be removed along with the breast, and during the operation you have to take efforts to preserve some structures like axillary vein, the cephalic vein and the long thoracic nerve of bell, that is a nerve to serratus anterior muscle. These structures should be preserved. So this is the radical mastectomy. Then in simple mastectomy, there is complete removal of breast, but axilla is not removed. Okay, the simple mastectomy, this means complete removal of breast, but axilla is left undisturbed except the region of axillary tail, which usually has attached to its few nodes low in the anterior group. Then we'll see the role of radiotherapy. It can be seen that in the local or regional management of operable breast cancer, radiotherapy and surgery, they are often complementary. Where the conservative surgery is practiced, radiotherapy plays a major role treating those areas which are not included in the operative field, that is the remaining breast and regional nodes. After simple mastectomy, radiotherapy to the axilla may be indicated. Then after radical mastectomy, the axilla does not require irradiation, which is usually confined to those lymph node area not included in the standard surgical field, that is internal mammary and supraclavicular lymph nodes. The skin flaps sometimes also irradiated if the primary tumor is large or tethered to skin. This post-operative irradiation doesn't improve survival, but it does reduce the incidence of local recurrence. And fears that radiotherapy might decrease survival by depressing the patient's immunity, it is not confirmed. So this is the role of radiotherapy in the breast cancer. So the treatment of breast cancer is depends upon the stage of the disease. In the stage first and stage second is operable. The operative procedures that include radical mastectomy and simple mastectomy. The radical mastectomy includes removing the whole breast along with other structures that I have explained you, and the simple mastectomy will include complete removal of breast, but the axilla is preserved. Okay, this CA breast can be asked for long question for 20 marks. So the homework for today is you have to write the whole long question of carcinoma of breast. Okay, that's all about today. Thank you.